All right. So yeah, I've seen this paper for a little bit from Paul, and I was really excited because I agree there are some really strong complementarities here. In fact, I'm supposed to give a kind of general talk, and I was thinking about sort of combining the two of them and what their messages were. This
You can even take credit.
I'm sorry.
We'll let you take credit.
So this is, I'll try to just be very brief. I only have time to give you a bird's eye view, but this is work on cost sharing in medical care and its relationship to adult mortality, a number of other things, but we think that our contribution is relatively greater on that consequence of it. We'll be talking about some evidence from Colombia. This is joint work with Giancarlo Buitrago, Javier Amaya Nieto, both at the National University of Colombia, and Marcos Vera Hernandez at UCL. So I didn't quite know how to approach a 12-minute presentation. I figured I would mismanage time, and so I just tried to tell you what our story is in one slide first. So we are in this project investigating the short and I think more importantly, the longer term consequences of outpatient cost sharing on service use spending. I won't be able to talk about everything and mortality among adults in the context of Colombia. For reasons that I'll summarize for you, we are adopting a dynamic regression discontinuity model to our context. So outpatient cost sharing and the Colombian health system is a step function of wages. And so with these discrete breaks in outpatient cost sharing across the continuous distribution of wages, that obviously lends itself to the sort of regression discontinuity approach. But in this context, cost sharing requirements can vary as frequently as month to month. There obviously can be very important temporal dependencies over time across months, and many of the effects that we're interested in emerge with a lag. So that motivates the way that we approach this empirically. In a nutshell, what we find is comparing higher versus lower outpatient cost sharing, and I'll be specific about these magnitudes in just a minute. Unsurprisingly, initially, we find that higher outpatient cost sharing reduces use of outpatient services. So demand is sloping downwards, surprise, surprise. When we look out over a period of time, it seems that higher outpatient cost sharing also reduces early detection and management of chronic diseases, which leads to the development of more severe disease over time. Something that I'll spend a little less time on today, but that we also find is that it also increases the use of costly hospital services and even total healthcare spending, and ultimately leads to measurable increases in mortality. So we think that our project has important implications for the design of socially optimal patient cost sharing, which we're not fully equipped to deal with in our project, but I'll talk about it again very briefly when I'm wrapping up here. So one slide on motivation. If you've ever taken a health economics class, and I think a few of you have, then you certainly know that the traditional objective of patient cost sharing under health insurance is to balance protection against financial risk with appropriate patient incentives against overuse of medical care. So the canonical concern about ex post moral hazard. There's a very large literature that builds on the early seminal literature on this, which has really drawn out much more nuance about what patient cost sharing actually accomplishes. I don't have time to go through all of that, but one that I'll just call out because it's related to the direction we're going in this project is some evidence that cost sharing is linked to reductions in preventive care and chronic disease detection, which is necessary for subsequent management. We think that our project is also related to another vein of literature on health in lower income countries, which focuses on cost sharing or really pricing of preventive health goods. And this literature, these technologies that are studied in this literature, you could certainly imagine could have important health effects. This literature doesn't generally focus on health outcomes or mortality, I suspect for reasons of sample size. These tend to be experimental studies with primary data collection. So in our project, we are reconsidering the relationship between outpatient cost sharing and health outcomes and mortality in particular. We're focusing on the universe of the formal sector workforce in Colombia. We're using linked administrative microdata in this project. So we're linking Colombian health system healthcare utilization records with payroll data and vital statistics at the individual month level over a period of 8 years from beginning of 2011 to the end of 2018. I think I'll skip the rest of this because I already motivated this for you. I'll say, since I don't have time to show you, we don't find much evidence of the natural things you would worry about given the direction we're going empirically. That is, we don't find much evidence of manipulation, and we find pretty good evidence of balance of time invariant characteristics in our system. Okay, so really simple figure to motivate or explain a little more precisely what we're looking at. So this is showing you co-payment amounts for outpatient care as a function of monthly earnings here on the horizontal axis. And so monthly earnings are shown in units of monthly minimum wages. And so you can see that as you approach from the left-hand side, the threshold at 5 times the monthly minimum wage, outpatient cost sharing is about $3.65 in 2020 terms, with a very large relative increase as you cross that threshold up to about $9.62 in 2020 terms. Interpretationally, I think it's important to know that for the most part, there's not cost sharing for other types of inpatient or other types of services. I'll just mention in passing, there's also a discontinuity in cost sharing at 2 times the monthly minimum wage. We're not focusing on that in this project because that same threshold is also used for some other public benefits as well in Colombia, which would be very hard to disentangle. All right, so by way of a little more warm up, this slide is showing you what I'll call a standard or static, by means of contrast, RD estimate for the contemporaneous relationship between outpatient cost sharing and use of outpatient services. So you can see here this drop right at the 5 monthly minimum wage threshold in use of outpatient services. This is a decline of about 6.6% in relative terms. The implied elasticity of demand for outpatient care by that estimate is about -0.1, so a little bit lower than some of the other estimates out there in the literature. Okay, so with this sort of in the background in your head, what we're really then interested in is what happens over a much longer period of time as people face differences in cost sharing month to month to month. So our approach, which I won't have time to go through with you in a lot of detail, draws on this very nice work by Savini, Pereda, and Rothstein in 2010. And so we take the dynamic regression discontinuity model that they've developed and we adapt it for our approach, for our setting rather. I guess important for me to say without going through all this is that there are 2 types of parameters that we're really interested in that come from this framework for each period or each month in our setup here. These are intention to treat and treatment untreated parameters. And let me just explain what they mean here in this context. So an intention to treat parameter in this framework captures the effect of higher versus lower outpatient cost sharing in a given month. It also bundles into it all of the subsequent downstream things that flow from that are correlated with it over time. And it then yields an estimate of the effect of that bundle on future outcomes. So more precisely in our setting, what it means is that an ITT parameter is capturing the effect of cost sharing in a month on a future outcome. It's also capturing the effect of cost sharing in a month on cost sharing in subsequent months. So the probability of facing a higher versus lower rate of cost sharing and then all of their subsequent effects on future outcomes as well. So by contrast, the other type of key parameter that comes from this framework is a treatment on treated parameter. So this parameter isolates the effect in our context of higher versus lower cost sharing in a given month. But this is now done conditional on cost sharing and all subsequent. So in other words, it does not incorporate the bundle of downstream things that flow from being above versus below the cost sharing threshold in that month. It's just the effect of cost sharing in that given month. And to help with intuition, we compute cumulative treatment on treated estimates in our project, which essentially says what would happen if one consistently faced higher cost sharing in every single month over time. We're not able to compute this for all types of outcomes, in particular ones that are absorbing states. So I think I'm already doing badly on time. Let me show you some results very briefly. So this slide is showing you dynamic RD estimates for outpatient care. So the top panel here is showing you estimates for, is showing you ITT estimates. And so across our entire study period, again, of about 8 years, you can see at very short lags, you see estimates that are extremely close to that standard or static RD estimate that I showed you before for outpatient care. So individuals facing higher outpatient cost sharing or using less outpatient care, this is negative then for some period of time. Eventually, it moves up towards zero, and our sample here, eventually it reaches zero after about 3 years or so. And then over an even longer period of time, it eventually turns positive. So why might, over a sufficiently long period of time, higher outpatient cost sharing lead to greater use of outpatient care? Well, one possibility that I'll show you a little bit more on in a second, consistent with past literature, is that less interaction with outpatient care, with the medical care system, and that modality is leading to more illness and more severe illness over time. The bottom panel here shows you cumulative treatment on treated estimates. So basically you see that when the estimates in the top panel are negative, you can see in the bottom panel that you have this steady decline in cumulative amount of outpatient care that patients are using. Eventually it sort of bottom outs in levels when the estimates in the top panel reach zero, and then they start to rise as the estimates in the top panel are positive. They don't ever reach all the way back to zero, meaning you don't ever really fully catch up in the total amount of outpatient care that you're using. To just spend one slide more on this possible interpretation that individuals are becoming sicker over time as a result of less outpatient care. This is showing you ITT estimates for prevalence and severity of chronic diseases. So we've measured this for major chronic conditions using a Charlson Comorbidity Index. You can see here that at short lags, that patients or individuals facing higher outpatient cost sharing have lower prevalence and severity of chronic conditions. Presumably they're showing up to have that detected less as they go to the doctor. You can see that that stays negative and then moves upward towards zero with a sort of similar temporal pattern to what I showed you for outpatient care, and then eventually becomes positive over longer periods of time at greater lags here as well. And this is becoming positive despite the fact that, if you recall, your use of outpatient services is never really sort of totally catching up. Okay, so ultimately, what does this mean for mortality, which is an important part of how we advertise the project? So this is showing you ITT estimates for mortality. This is in units of deaths per 10,000 workers. And this is showing you that these mortality estimates become positive, but are statistically indistinguishable from zero, and that's the case over quite a long period of time. But as you approach the end of our 8-year study period, these estimates then become statistically distinguishable from zero, rather. and are positive, the magnitude here, which I guess you can read off, but the implied 8-year mortality effect size is about 4 additional deaths per month per 10,000 workers, which is actually quite a large effect. It's a relative increase of about 11%. We've used an alternative approach to look at mortality effects of higher outpatient cost sharing using a duration model. And I'll just say, because I think I'm basically out of time, that we find very similar results. So here you see an implied effect size of about 4.6 additional deaths per month for 10,000 workers. So to wrap up very quickly, I think it's important to keep in mind that health or even mortality harms of patient cost sharing doesn't in and of itself mean that cost sharing is undesirable or even too big. But it does suggest that the costs, and in particular the health costs, we're showing of patient cost sharing over time may be larger than have previously been recognized. And so this may implicate some rethinking of socially optimal patient cost sharing. In our specific context, something I think we can say is that given that we find reductions in health or survival, and presumably reductions in other things that people value when they go to the doctor that we're not measuring, together with an increase in total healthcare spending, seem to imply that, at least in our context, that higher cost sharing is inferior to lower cost sharing. And I'd like to call out that I think, we're looking at an average across the formal sector workforce in Colombia. I think heterogeneous effects among less healthy and more vulnerable subgroups deserve a lot more attention. Even though the interpretation is trickier, we have looked at this at the 2 monthly minimum wage threshold as well, and effect sizes are larger in magnitude there. Although again, there's this compounding role of other public programs that use that. So let me stop there for the moment. Thanks very much.